So I'm going to implore the treating clinicians not to jump to resect this disease when they recur after they've already received adjuvant therapy. They need to be put on neoadjuvant studies. I think we shouldn't be operating on these patients and just saying, okay, let's give them an adjuvant therapy that we have no idea if it's going to work or not. And so that's, to me, is a data-free zone again. These patients need to be put on a neoadjuvant trial so you can see what therapies are actually effective in this patient population. So that would be my kind of advertisement for...
But Merrick, you're a world-known expert, not only in surgery, but also translational research. So, you know, do you think that the community surgeon is following your guidance and your recommendation?
Yeah, but that's why we're having this discussion.
No,
right?
but you know, I completely agree with you. That is a perfect scenario for neoadjuvant treatment, and maybe the neoadjuvant treatment is identifying the right candidate for the next line of treatment, because you can see immediately after 4 weeks of treatment or a maximum of 8 or 12 weeks of treatment if the patient is responding in the lymph node or in the skin metastasis. So coming to the neoadjuvant arena, I mean, there's exciting data from 3 clinical trials out, and one was presented here at ESMO. It's a trial on neoadjuvant ipilimumab and nivolumab. Is that exciting data, Caroline?
I think it is. Actually, there is the first generation of this neoadjuvant trial has just been published this month. It's online in Nature Medicine. It's a team of Christian Blank in the NKI in Holland. So they initially tried the usual regimen of ipi-nivo in the adjuvant setting in the first so-called OPACIN trial, and it was quite promising in terms of a pathological complete response, and it was not exactly what they expected in terms of translational research, but still the neoadjuvant versus the adjuvant gave rise to more clones specific for the tumor in the blood. But it was highly toxic. I mean, it was incredibly toxic. It was like 90% of this very small group of patients with stage grade 3 or above adverse event, and very severe adverse event. So it was not feasible, in fact, because of the toxicity. But what we heard at this meeting, it's another OPACIN, so he called it OPACIN Neo, where they tried 3 different regimens. And one of them is with a reduced dose of ipilimumab, 1 milligram instead of 3, and there the toxicity is much better. It's let's say, tolerable. And still there is this very interesting high rate of pathological complete response. We don't know yet if it's going to be a very good surrogate marker for survival, but at least it's extremely encouraging. So yes, very exciting data, I would say. And I would like to really acknowledge the fact that this team and the others who did this work on neoadjuvant trial, they did a big effort to do a very sophisticated and very smart immunomonitoring, and it's going to be very helpful.
So you mentioned the example, Merrick, of a patient who has received a PD-1 antibody in the adjuvant setting. This patient shows a progressive disease with some growth of lymph node metastases. So that would be a good scenario to test dabrafenib and trametinib in a neoadjuvant setting, and there's data out. Would you like to summarize the current data on neoadjuvant treatment, and if a patient is responding either with a complete response pathologically confirmed or with a partial response, is this the ideal candidate to continue after the full resection with an adjuvant treatment?
Yeah, so it's important to recognize that the data that we have now available that's mature in the neoadjuvant setting is all pretty much first-line therapy. So these are not patients who've had adjuvant therapy, then relapsed, and then were eligible for neo. So it's important to know that the data that's available now would be for the treatment-naive patients. And in our trial that we did with what we called neoadjuvant plus adjuvant, so they got neoadjuvant therapy for 8 weeks of dabrafenib and trametinib, had surgery, and then had adjuvant therapy. Was it for a year, Mike? Or 11?
Completed a year of treatment.
So complete a whole year of therapy for dabrafenib and trametinib, depending on the toxicity. And a good surrogate marker for outcome has been whether or not the patients received a near complete response or a complete pathologic response. And the interesting thing is that our imaging studies probably underestimated the extent of our pathologic complete response. So the patient may have what appears to be residual clinical disease either on physical exam or on imaging studies, but in many of those cases, the patient actually undergoes a complete pathologic response. So that's a great marker to show that the therapy is working, and whether or not they need the additional therapy is a different question. But based on targeted therapies, the mechanisms of response may be different than our immunotherapies. That they may, in patients receiving immunotherapy, they may not need a whole year of therapy, but we don't really understand the difference in the mechanisms. So I think for now we would stick to the concept of the patient receiving a year of therapy if they could tolerate it. So Mike, maybe you have a comment.
Yeah, so just to add a little bit. So the pathologic complete response rate in that trial was 58%, which is much higher than the complete response rate we see in stage 4 patients. And at the time that we published the results, for those patients who received neoadjuvant therapy, none of the patients who had achieved a path CR had developed distant metastatic disease. The only distant relapses had happened in patients who hadn't achieved a path CR. So again, it's clear that adjuvant dabrafenib trametinib can provide tremendous clinical benefit, but the idea that after sort of 8 weeks of therapy, you could potentially identify the patients who would continue to do well with this treatment is potentially the paradigm shift, I think, that neoadjuvant therapy would offer.
Yep.
And also in this trial, you were obliged to stop early because there were 7 patients with no neoadjuvant.
Right.
At 18 months, I think they were all dead. And the 14 patients with neoadjuvant, 10 of them were alive at 18 months.
We had to stop because there was a 60-fold improvement in relapse-free survival.
But it was relapse-free survival. It wasn't death. It wasn't death. So it was relapse-free survival.
Okay.
So a quick comment on just the practicality. So one of the things that comes up is that we're making this tremendous progress in melanoma and actually in other cancers as well. Many drugs coming forward that have substantial financial complications as well, especially for other health systems outside the US.
We call it financial toxicity.
Yeah. But I want to emphasize how important these kinds of studies are to emphasize that there are populations of patients that we can cure, and perhaps they only need shorter windows of therapy. And if we could start moving our research towards that, it would actually help with these questions in the metastatic setting and all over in terms of optimal usage of these agents that won't kill the health system.
And to Caroline's point, the original Opacin study, and again, we had a parallel study at MD Anderson randomizing to neoadjuvant Nivo versus Ipi-Nivo, is, as you said, many patients had very significant toxicity and therefore received a very short window of treatment, 1 or 2 doses of the Ipi-Nivo combination. The interesting part is that in the data that's been presented, none of those patients who achieved response, even with those 1 or 2 doses, has relapsed to this point. And so this question of actually could you do very short-term therapy, even with toxic regimens, be feasible?
So just one quick comment before we move to the field of metastatic disease stage 4. There was a third trial which is not being published by now, but it was released at AACR 2018 on adjuvant pembrolizumab, and interestingly, that was one shot, one infusion of adjuvant pembrolizumab, leading to neoadjuvant pembrolizumab, leading to 30% of complete or almost complete, with less than 10% viable tumor cells, pathological responses. And I think that is also very exciting if you believe it's just one shot. And after 3 weeks, the resection was done. So that brings us back to Merrick's idea of a surgeon who is interested in systemic treatment first, right?
So it's really interesting. In that trial, the timeline was short. So they had surgery after 1 cycle. None of the patients had significant progression that they couldn't have surgery. In our trial of the single agent nivolumab versus the combination checkpoint blocking agent, in the single agent arm, we did have a couple patients who progressed beyond the point of having surgery, but then again, the therapy was longer. We did 9 or 12 weeks, Mike, was it 9 weeks?
Yeah.
So 3 cycles.
8 or 9 weeks.
So we there was more time for a patient to progress, actually. So biologically, you were finding the bad actors because you waited long enough for them to potentially have a recurrence. In the other trial I think it's from University of Pennsylvania, only had 1 cycle, and they had surgery like right after the 1 cycle. So like in 3 weeks, they had surgery.